Hi, everyone. Thanks so much for joining our webinar. We're going to get started in a few seconds. We'll just let a few more people join. But if you're here for the Inside the Research INSU Prisons webinar, you're in the right place. So thanks so much for joining us, and good morning, good afternoon, good evening to you wherever you are globally. I think we have a quorum from an international audience. Liv, can you go to the next slide? So I'll just start with some preamble as more people are joining. Many people who are on the webinar will be familiar with INSU. INSU is a global network dedicated to improving the health of people who use drugs with a specific focus on hepatitis C, infectious diseases, and harms that occur from drug use. INSU Prisons is a prisons-focused network and special interest group of INSU that's committed to advancing scientific knowledge exchange and advocacy for Hep C in correctional settings. Next slide. And INSU Prisons is led by an executive committee. So our chair is Professor Andrew Lloyd, who's on the call from the Australian National Prisons Hepatitis Network in the Kirby in New South Wales, Australia. I'm Matt Akiyama. I'm from Albert Einstein College of Medicine, Montefiore Medical Center in New York, in the US. Joaquin Cabezas, who's on the call today as well, is from Marquès de Valdecilla University Hospital in Santander, Spain. Dr. Nadine Kronfli is from the McGill University Health Center in Montreal, Quebec, Canada. Yumi Sheehan is also from the Australian National Prisons Hepatitis Network and the Kirby. Julia Sheehan is from the Hepatitis C Trust in London in the UK. And Nanzo Maduka, who I'm hoping will be able to join us, is one of the co-facilitators, hopefully, of this webinar. He's coming to us from the Benster Development Foundation in Nigeria. And Nanzo's on. Great. So a little bit about INSU Prisons. So we and the purpose of this webinar. So this webinar was born in 2020 when we put together a list of the most relevant publications in carceral health and viral hepatitis from 2019 to 2020. And we thought this was a successful endeavor to sort of collate the literature and really highlight the key publications in our field. And so we decided to create a bibliography as an annual activity, and we've been doing so every year since 2020. Today, we're welcoming authors from research papers that were highlighted in the 2023 INSU Prisons bibliography as considered to be outstanding or of special interest by the INSU Prisons Executive Committee. And if you're interested in looking at the bibliography, you can either scan the QR code that's on the slide, or we can send you the link that's on the slide as well. This is our third INSU Prisons bibliography webinar, so it's becoming an annual affair. Next slide. I'll hand it over to Nanzo to introduce you to the program. Nanzo, are you able to unmute? If Nanzo is not able to unmute, I will proceed with the program. So we're going to start with welcome and introductions, which we're doing currently. The first talk is going to be by Dr. Ann Spaulding from the Rollins School of Public Health. And Ann is going to be discussing estimates of hepatitis C seroprevalence and viremia in state prison populations in the US. We're then going to move on to Yumi Sheehan from the Kirby, who's going to be discussing a one-stop shop point of care HCV RNA testing intervention to enhance treatment uptake in a reception prison, which is the PIVOT study. Chris Byrne is not able to join us from the University of Dundee, but he has sent us a pre-recorded talk on a mixed methods evaluation of point of care HCV RNA testing in a Scottish prison. Quamrun Masuda also may not be able to join, but we have a recording for her as well if she's unable. She was in transit and maybe catching a flight on outcomes of pharmacist-led treatment of hepatitis C in the Virginia Department of Corrections here in the US as well. Next will be Behzad Hajarizadeh from the Kirby, who will be discussing incidence of hepatitis C in the prison setting, the STOP-C study, a follow-up study to the main STOP-C study. And then we're going to have a facilitated panel discussion of 30 minutes. So as people are presenting, please prepare your questions. Please feel free to submit them in the chat or write them down. It would be great if you're able to go on camera and unmute to ask your questions, but putting them in the chat is completely fine as well. And then we'll close with some final remarks. Bit of housekeeping. Please feel free to turn on your videos. We're a very friendly group and would love to see your faces. Please keep your microphone off, though, on mute until the Q&A period. As I said, post any questions to the chat box as they arise. We'll collate them and save them for the Q&A. Please be respectful at all times to the fellow panelists or fellow attendees as well as the panelists. And most importantly, please have fun. This is supposed to be an interactive discussion, and we want you to really engage with the research that's being presented. We like to look at this as a backstage view at the research. We know how hard prison research is to do, so please feel free to ask the researchers questions about the research they've done as well, especially if you're interested in doing prison research or currently doing it. Next slide. So I'm Dr. Matt Akiyama. I'm an associate professor of medicine in the Division of General Internal Medicine and Infectious Diseases at Montefiore and Albert Einstein. Not sure if Nanzo is available to introduce himself yet. If not, hopefully Nanzo can join us, especially for the Q&A. He's a executive director at the Bensler Development Foundation in Nigeria. I'll pass it over to you, Liv, to introduce yourself.
Thanks, Matt. My name's Livia Dawson. I work as the program manager for INHSU and very delighted to be here today and supporting the webinar and the broader work and programming of the INHSU Prison Special Interest Group. So it's lovely to be here.
Thanks, Liv. And just to introduce our presenters, so as mentioned, Anne Spaulding is an infectious diseases researcher at the Rollins School of Public Health in Atlanta in the US. Yumi Sheehan is a research project manager and PhD candidate at the Kirby Institute at the University of New South Wales in Australia. Dr. Chris Byrne is a public health intelligence advisor at Public Health Scotland and the honorary fellow at the Dundee University. Next slide. Assistant Prof. Quamrun Masuda is a pharmacist specialist at in the Health Services Unit at the Virginia Department of Corrections. And a Prof. Behzad Hajarizadeh is an associate professor and viral hepatitis clinician researcher in the Kirby and University of New South Wales, Australia. So all-star lineup from around the globe for you today. And without further ado, I'll pass it over to Anne to take us away with the first talk. Over to you, Anne.
Okay. Thank you, Matt. I'm just going to have my first slide here. Okay, so my talk is going to be on what it took to produce an estimate of the prevalence of hepatitis C antibodies and viremia in U.S. state prison populations. And this is in the country that usually tops the list in the percentage of our population that we incarcerate. From time to time, there'll be a contender, but every year we seem to be near the top. The U.S. incarcerates and has basically an epidemic of incarceration. And I want to give a shout out to Alexandra Kaufman, who will be graduating in just a couple of days with her MPH, who helped me put these slides together, and also to the National Science Foundation, who funded this research. I'm going to start with a bit of a background of why hepatitis C prevalence estimations are important for the U.S. epidemic. I'm going to talk about the story behind the paper, how data collection proceeded, and then we'll discuss the results. So, as I mentioned, the U.S. is a country that has many of its individuals incarcerated. Our war on drugs resulted in having many people who inject drugs incarcerated, which means that 1 out of 3 people who have hepatitis C in our country spend part of the year incarcerated. They may not spend the entire year behind bars. Our jails have people going in and out with a constant churn. Our prisons have a slower incarceration and release dynamics. This is a paper that was written by Dr. He, and the senior author was Dr. Chatwal, who's at Mass General now, showing that hepatitis C management in prisons will be essential in order to get elimination in our nation. And this paper also showed that treating people while they're in prison and not kicking the can down the road is a cost-effective approach towards hepatitis C management. And just to give people a bit of an orientation, can we screen for hepatitis C while people are incarcerated? And we have our correctional system in the US divided in two segments, and one is jails, which are short-term facilities of people awaiting trial. And when people are convicted, they go to prisons. And this separation is one of the phenomenons of the US carceral system. It's different in every country. But just to point out on this slide that people rapidly move through US jails, and half of the people coming in tonight will be gone well within a week. Most people on average will be spending about 2 weeks. There's a lot of people coming in, a lot of people coming out. And we have many jails that will do some testing for HIV, but since the responsibility for health is just so short for our jails, we usually are not testing for Hep C in our jails. And many people with Hep C enter and leave unaware of their infection. On the other hand, our prisons, the care for people's health in prisons is more extensive. People stay a mean of 3 years. And so there has been an increasing amount of attention paid to hepatitis C. Most of the treatment in the US system occurs within prisons. 95% of people who spend part of the year, at least part of the year incarcerated, though, are in jails. So treating in prison definitely is catching quite a few people with hepatitis C. A lot of people who are behind bars at some point during the year will not get tested and treated if they don't have a conviction that transfers them into our prison system. So we did do a review. We've done a number of surveys trying to find out how many people in our state prisons have hepatitis C. And I'll be discussing our fourth survey, but we did our first survey 25 years ago when I was still medical director in Rhode Island, and we had 36 states replying. Some states said, oh, we don't seem to have much of that here. They had never tested, but they were assured that they were pretty sure they didn't have hepatitis C. By the time we did our next survey 10 years ago, the states were very much aware of their hepatitis C, due mostly because there were a lot of lawsuits in the interim. We did a third survey in 2017, and we wanted to do an update in 2018. We started in on an update. This paper was published last fall, where we gave data on the estimates of hepatitis C seroprevalence and viremia in state prison systems. And it was published in a special supplement to the Journal of Infectious Disease that was dedicated to hepatitis C elimination. What did it take to complete this survey and write the manuscript? So as I mentioned, we were trying to put this together late 2018, 2019. We reached out to the Correctional Leadership Association, which is an association of basically the head honcho of every prison system, the commissioner, the director. They have different titles, but every state has one person who leads their prison system. So it reached all 50 people by going through their professional association. And we asked them to give the survey to their statewide medical director, and the link was for a Qualtrics survey, and we had about 1/3 of states responding. Something happened about a year after we started this survey. People didn't have much time at that point to respond. So COVID basically stopped us. 2022, as COVID was coming under control, we started the survey up again. And at this point, the Correctional Leadership Association had had so many requests for data from their membership that they said, we're done with doing surveys for all of you medical people, and they turned down their request. So basically, we were on our own to try to reach the states who hadn't responded earlier to try to see if there were any updates. As we were confronted with state systems that were less than able to have enough bandwidth to respond to a survey, we started scouring court cases, looking in gray literature, and came up with most states, some data on most states. We sent the preliminary data back to the Correctional Leadership Association, and as they were seeing that this was coming together with data that would basically show the world how much hepatitis C was in the prisons, they were able to send out preliminary results of the survey. And I think that's what prompted the delinquent states to respond. And I sent out a near final draft so the states would know what was going to be coming on down the lane. I didn't want people to be surprised. And we eventually obtained some data from all 50 states. Some of the data was, we don't test at all for hepatitis C. Some of the data was just from the court cases, and some was from the medical director themselves giving us data. Results of the survey. We do have our data published on a website, hepcorrections.org. This is data from our previous survey was here, and we have an update that is making its way back to this website. The antibody seroprevalence varies by our 50 states, and this heat map shows that it's well above 20% in some states and much lower in other states. And the what this shows is that there are some areas of the country that do seem to be more heavily affected by hepatitis C, but it's not just like sharp geographic lines of our infection and of our epidemic. This shows viremia, and you can see that some of the states whose have antibody at very high levels may have very little viremia. For instance, California, and this depends on how much treatment the state has had. And in states where there's been aggressive treatment, there has been very low prevalence of people who still are viremic. Some states, such as California, for instance, the infectious disease doctors are having a hard time finding people who are infected who want to have treatment. There's so few people. In other states, they're still not getting to all the people who want to be treated. So again, there's not a sharp geographic line of where viremia is highest. So there have been issues with getting data. There's variability in what is reported. Some states only know the prevalence among entry cohorts. If they test people at entry, they can tell you what the prevalence is then, but they might not be able to get you a cross-section of their entire population. Others can only give you the cross-section of the house population, and still others have only a convenient sample that may or may not be biased. We may, in some states, have only antibody data and not viremia. If a state reported doing very little treatment, we were assuming that viremia was present in 75% of the population with antibodies. And we also had data that may have been true at one point in time, but we all know prevalence changes with time, with new populations coming in, and as more and more of the infected persons get treatment. We do have some data, and in many states, it is an exact enumeration. Still, there are people in other infectious disease epidemiologists who say that our data, that they have better data because they've done a meta-analysis of many small studies, and certainly their data is published data rather than data just from the prisons. And I'd love to talk about that afterwards. I do believe an exact enumeration of the cases is probably a better snapshot of where we are today than people pulling out studies and only looking at data from published state studies and not looking at exact enumeration state by state. Our next step is to try to fill in the gaps. And we do have people in every state of our country who will be picked up by our Federal Bureau of Prisons to serve sentences on federal charges. And so that has basically sampling from the criminal justice population, a population that for the most part have been through our state prison system. And it's basically a level playing field from every state who will go to Federal Bureau of Prisons, same charges for every state. And we have been trying to look backwards. So depending on what the prevalence of individuals coming from my state of Georgia, another state of New York, etc., is as they go into the Bureau of Prisons, we can see what percentage of the, how it relates to the state prevalence, and then do back calculation to try to figure out what the prevalence is for states that are missing data. So that's basically where we are. And I think I've probably gone over my 10 minutes. So thank you everyone for your attention, and I'm going to hand it back.
Just by a bit. Thanks so much, Anne. It's such a monumental effort, and then there will be a lot. There's already a question in the Q&A that we'll get back to. So thank you so much. We'll pass it on to Yumi. And as a reminder, if you can keep the talks within 10 minutes so we don't eat into the Q&A, that would be great. Over to you, Yumi.
Thanks, Matt. Okay, just confirming that's all good.
Looks
yes.
Great.
Lovely, thank you. So thank you so much for the invitation to present today. I'm going to be talking about the PIVOT study, which was a one-stop shop point of care hepatitis C testing intervention, looking at improving treatment uptake in a reception prison in New South Wales in Australia. So I don't receive any personal remuneration from pharma. So I'm just wanting to set the scene a little bit for Australia. So Australia initially made quite good progress towards elimination of hepatitis C. And a huge facilitator of this was the availability of the highly effective DAAs on our pharmaceutical benefits scheme. And that allowed access to these DAAs for people across Australia. And there were special arrangements made for access to these DAAs for people in prison as well. And so since the listing on the PBS in 2016, we've actually done quite well at identifying and treating a high number of people. But as you can see in this figure here, which shows the number of individuals initiating treatment from 2016 to the end of 2022, the treatment initiations are actually on a downward trend, and we're no longer on track to achieve the WHO 2030 targets. So to try and get back on track, we really need to continue to actively case find and test and treat all of those people with Hep C, in particular amongst high-risk populations, such as people who inject drugs. Because of the high rates of drug-related incarcerations, there are also high rates of injecting drug use in the prisons. There's also a high chronic Hep C prevalence in the prisons, and at the time of the study in Australia, this was around 10 to 15%. Unfortunately, this makes prisons kind of an opportune venue for testing and treatment efforts. In Australia, they've actually been considered as priority setting in the National Elimination Strategy, and I know that that's the same globally as well. Taking a look at national treatment initiations. So in 2016, all the way to 2020, of all the treatment initiations that happened nationally, 6% in 2016 happened from the prisons. And by 2022, this proportion had actually increased to over a third of the national total. So you can just see that there is an increasing proportion of people who are being treated in the prison setting in Australia. But we know that this still only represents a portion of the people with hepatitis C who are eligible for treatment, who are actually initiating treatment in the prisons. So this highlights that there's a growing importance for prisons in national elimination, given the growing contributions to national totals, but we still need some more strategies to try and continue to engage in individuals with testing and treatment in the setting. So just to set the scene very briefly about the Australian prison setting. So as Anne mentioned, prisons are unique, very unique structures. There's lots of overcrowding, complex, challenging settings. In Australia, we have around 110 prisons across the country. There's a lot of movement across the setting with people coming in and out of the setting, very short periods of incarceration. There's high prevalence, frequent movements, limited nursing capacity, and lots of other competing priorities. And all of these together mean that there are challenges to people in prison efficiently completing the hepatitis care, or I guess engaging with and completing the hepatitis care cascade and making their way actually onto treatment. So reception prisons are prisons that take those who are just coming into the prison from the community. They generally have high turnover and high throughput, sometimes ranging from around 20 receptions per week all the way up to 20 per day. And the prison reception period provides an opportunity to try and engage high numbers of people for testing and treatment just as they're coming into the prison setting. So I won't go into too much detail about the care cascade, but this is just an example of a typical pathway that someone does take when they're coming into prison. It's important to note that there are some variations across the different jurisdictions in Australia, but this is a fairly typical pathway. The pathway generally involves consultations with lots of different healthcare providers. This could be nurses, GPs, or specialists, and in general, it can take a long time, sometimes several weeks or even months, for people to move through this pathway onto treatment. So as you can see, there are ample opportunities for dropping off the care cascade essentially at any time throughout this journey. And as you can imagine, the less steps there are in this care cascade, the more opportunity for retention. And so this really highlights the need for improved efficiencies or even streamlining of the care cascade. Again, I won't go into too much detail about this, as I'm sure people are aware of the Cepheid's expert viral lobe finger stick assay, but we know that this provides a great opportunity for improved efficiencies in the prisons. Yes, I won't go into too much detail about this, as I know that we're kind of short on time. So the primary objective of the PIVOT study was to evaluate a one-stop shop intervention that integrates that point of care testing, so that rapid 60-minute RNA testing, a FibroScan, a clinical assessment, and a fast-tracked DAA prescription on treatment uptake among people incarcerated recently. The primary endpoint was treatment initiation at 12 weeks from enrollment, and a couple of the key secondary objectives were to compare the proportion of people tested for Hep C prior to and following the intervention, as well as to compare the time taken from enrollment to each step in the care cascade, in particular, time to treatment initiation. The PIVOT study was conducted at a single reception prison on the mid-north coast of New South Wales, Australia, all newly incarcerated adult males. So those were people who were incarcerated within the previous 6 weeks and who had no prior experience with DAAs were eligible for inclusion. Those with Hep B co-infection, an invalid FibroScan result, or had evidence of cirrhosis were excluded from initiating treatment through the study. They were referred in for standard of care. So PIVOT was a prospective, non-concurrent controlled study with a control and an intervention phase. In the control phase, people were enrolled from 2019 to May 2020. And in this phase, participants were enrolled. They underwent a nurse-led interview-style survey, and then we just followed them as they went through the standard of care pathway for testing and treatment. And the number of participants initiated on treatment through the standard of care were recorded. In the intervention phase, which enrolled participants from June 2020 to April 2021, we enrolled participants and they underwent that one-stop shop intervention. So for those who are RNA positive, they were then initiated treatment through the study, and then they were followed up at ETR and SVR12 with point-of-care tests to determine cure. And again, the number of participants initiated on treatment through the intervention phase were reported. So what is the one-stop shop intervention? So I'm going to take a little bit of a closer look at this one-stop shop intervention. So this one-stop shop combines all the key assessments for hepatitis C into a single nurse-led visit. So all participants in this one-stop shop had a point-of-care Hep C RNA test using that fingerstick viral load assay. They had a FibroScan for liver disease assessment. They had a general clinical assessment, and then a nurse-led interview-style survey. All of that happened within the same 60-minute visit. For those who were RNA positive from that point-of-care test, they then had fast-track prescription for pangenotypic GLP-1, so that's Mavorite, from a specialist via telehealth, and that usually happened the same day. And then they also had fast-track treatment initiation, and that generally happened within a couple to a few days. We did have a special arrangement with the central pharmacy in New South Wales, which was based in Sydney, and we had priority dispensing, which was really great, but it did still take time for those drugs to actually make their way from Sydney up to the prison site, which was in the north of our state, on the mid-north coast of New South Wales. So the participant characteristics, so primarily age, Aboriginal and Torres Strait Islander status, previous incarceration, injecting drug use, were all comparable amongst participants in both the control and the intervention phase. So now looking at some of the results from the PIVOT study. So this is showing the throughput and the testing and treatment uptake in the standard of care arm versus the one-stop shop intervention. So it is important to note that this study was conducted at a prison that's actually considered to be pretty good. So one that has a pretty good, well-established hepatitis service delivery in that standard of care. So just walking through this, so the first 239 people who were enrolled in the study, and enrollment happened shortly after reception, were observed as they made their way through the standard of care pathway. So of the 239, 115 reported, or 48% reported having risks for hepatitis C. 63 had either antibody or an RNA test, of whom 29%, 18 or 29% were RNA positive. 22% of those initiated treatment, and there were no SVRs achieved in the standard of care. In the intervention phase, the next 301 people who were enrolled in the study, and again, enrollment happened shortly after reception, had this one-stop shop intervention. So of the 301, 42 were identified as being at risk for hepatitis C. Almost everybody had a point-of-care test, so 99% had a point-of-care test, of whom 10% were found to be RNA positive. 28 or 93% of those initiated on treatment, 15 completed treatment while they were in prison, and 11 achieved SVR. So as you can see, there is a dramatic increase in both the testing uptake from 26% to 99%, as well as the treatment uptake from 22% to 93% in the intervention compared with the standard of care. Time to treatment initiation was also markedly reduced from a median of 99 days to 6 days in the intervention phase. And all of these were statistically significant. So you can, so this study extends some of the findings from other prison-based and community-based studies that involve the point-of-care testing, and it's really establishing the evidence base for that one-stop shop. So having all of the assessments all in the single visit. A likely facilitator to the high treatment uptake in our study was that we had funding for a dedicated research nurse and a correctional officer, and we also had a dedicated clinic space at the prison. And rather than any kind of standalone element, the combined package of all of those one-stop shop elements was really a likely facilitator or contributor to the enhanced treatment uptake in our study. And we suspect that unbundling those key elements will likely lead to delays unless all of the assessments happen on site and on the same day. And point of care testing is really being scaled up in prisons across Australia as well as globally. So in conclusion, a one-stop shop intervention that integrates point of care testing was shown to enhance testing and treatment uptake, and it markedly reduced time and increased efficiencies for treatment initiation in the prison. And this really helped with overcoming some of the key barriers to treatment scale up in the prison. And continuing to scale up point of care testing in prisons more broadly will be really helpful and really good for national elimination. That's happening across the country in Australia now. So just a couple of acknowledgements, all of the participants and collaborators, and all of the Pivot study team, as well as our funders, ABVIN, the National Health and Medical Research Council, and Cepheid for all of the point of care tests and the machines. Great, thank you so much.
Thanks, Yumi. Amazing study. Thank you so much for being leaders in this one-stop shop model, to you and Andrew and the rest of your team. Really outstanding work. We're going to go straight to Chris Byrne's presentation. It's recorded. So Liv, if we can get that started, that'd be great. Also, just as a reminder, as this is loading, please feel free to keep putting your questions in the chat. We've got one so far, but please keep them coming. And if you have questions for Chris or Quamrun, we'll try and get those questions to them. They're not going to be able to participate in the Q&A, but we'll try and get those questions to them so that they can answer them for you.
How's this, Matt? Can we see slides yet?
We see the presentation, but hasn't started playing yet.
Perfect. Give me a thumbs up if you can hear this when I start playing now.
Okay.
Hello, good morning, good afternoon, good evening, wherever you are in the world. My name is Chris Byrne. I work at Public Health Scotland and the University of Dundee. And I'd just like to start by thanking INHSU Prisons for the chance to present this work. It's been a privilege to get to share this with you all. And my co-authors there are named on the slide. And essentially this study is looking at implementing point-of-care RNA testing in a maximum security prison in the region where I work in Tayside in Scotland. And hopefully you'll find it interesting and it'll stimulate a bit of useful discussion in the panel afterwards. So before we start, a few disclosures. That Cepheid provided the diagnostic platforms and assays free of charge, as well as funding for a part-time coordinator for the work, but there's no other relevant disclosures other than what are on the slide. So as a bit of background, I won't get into too much detail because if you're here, you already know quite a lot about this, I suspect, but many people worldwide who inject drugs are incarcerated. And in the UK, around 4 in 10 people in prison injected a drug in the month prior to their arrest. In Scotland, about 7 in 10 people have a reactive test for illicit drugs upon reception to prison, and quite a high proportion of those are commonly injected drugs like opioids and cocaine. So there's a substantial and enduring risk of bloodborne virus transmission or transmission in Scottish prisons. And we do have what's been termed a remand problem across the prison estate in Scotland, where we have a very high proportion of the prison population are only part year. So essentially they're on remand waiting sentencing, or they are on short-term sentences on the way to be liberated to the community and so on. But the bottom line is essentially it means we have a highly transient prison population, and our window for healthcare engagement, including for bloodborne viruses like hepatitis C, is relatively narrow in the face of that substantial and enduring risk that I just mentioned. And in terms of where this work was undertaken, so I'm based in Scotland, in Tayside, which is in the east of Scotland, about 400,000 people. Dundee, the main city in the region, has the highest per head incarceration rate in the country and an historically high burden of hepatitis C among people who inject drugs. So we've got a very dynamic, if you like, sort of situation between residents within Dundee and Tayside, where there's quite a lot of ongoing drug use and burden of hepatitis C and transition in and out of this particular prison. Across Scotland, and prisons opt-out testing for hepatitis C and other BVVs is in place. and routine testing once people are resident within their establishments. And the one we did this evaluation in, is pictured in the bottom right, is HMP Perth. I've been informed previously it was constructed to hold Napoleonic Wars prisoners, but haven't been able to independently verify that. And it is the oldest prison in Scotland. It typically holds about 700 people a day on mixed duration sentences. It's maximum security category A, and healthcare is provided on site by the NHS, an integrated health centre. So, as I said, opt-out testing is in place with conventional phlebotomy and dried blood spot samples. The timelines associated with those at the time quite lengthy. So Perth's about half an hour away from Dundee, and conventional sort of phlebotomy would be sent to Dundee for analysis, take a few days to be processed. But dry blood spot sampling, so typically used for people with challenging venous access, would be sent to Glasgow because we didn't test locally for RNA and DBS at the time. And that could take up to 4 weeks, maybe 5 sometimes. So what we wanted to do was to understand if we integrated point-of-care RNA testing as part of our conventional or typical offering within the prison, alongside dry blood spot and phlebotomy, what would the impact be in terms of shortening time to treatment for people? What would the cost be relative to the benefits in monetary terms? And what were the barriers and facilitators to implementing it? So we did some interviews and used a framework called the Consolidated Framework for Implementation Research to try to frame that analysis. So as I said, we integrated it into the prison pathway, let it run its course essentially alongside other testing methods. Nurses and people in prison could choose which method to use at the time of the test. Then we looked retrospectively at what the outcomes were and divvied up the cohort into essentially a 1-year pre-pilot phase where only conventional testing was offered, and then sort of a pilot phase group split in 2, where there was a group who were tested conventionally, and then there was the group that tested with the point-of-care gene expert. Used various sort of statistical methods, survival methods to test for differences, and divided the total cost for diagnosis and treatment by the benefits of that, which is essentially a cure, because we didn't have the data to do a full economic analysis. As I mentioned, we did interviews with staff and used a framework to analyze those. So in terms of results, going down the right-hand side of the screen here, you can see there were close to 400 tests, RNA tests done during the study period. And about 45% of those with the gene expert, and that turned up 91 RNA positive cases. After various exclusions for different reasons, you can see down the bottom of this flowchart the 3 different groups I mentioned before. So on the left-hand side, that conventionally tested pre-pilot group. In the middle there, conventionally tested group in the pilot phase, and then on the right-hand side, the gene expert point-of-care group during the pilot phase. And we did see a 36% improvement in linkage to treatment, so moving from that diagnosis to initiating treatment in the pilot phase for the point-of-care group relative to conventional testing. However, we did see also in this group that there was a higher rate of loss to follow-up after treatment, which might suggest that the health care staff in the prison did target testing towards a slightly more transient group potentially than the conventional methods potentially. When we looked at the survival analysis, you can see on the right-hand side of your screen here, there was the median time to treatment for the gene expert is 19 days. For conventional testing during the pre-pilot phase was 33 days, and during the pilot with conventional methods was 50 days. And on the left-hand side here in Kaplan-Meier analysis with a log rank testing, you can see that these differences were significant. When we modeled this out using Cox proportional hazards models, we could see, so comparing the pre-pilot phase to the pilot with the RNA testing, there was a 91% higher hazard of transitioning to treatment after your test, if you were tested with the gene expert, and this was substantially higher if you compared just the pilot phase, so the point-of-care group, the conventional group within the pilot. But I think the 91% is a much more realistic comparison, because we were unfortunately impacted by COVID quite substantially during the pilot that we had here. So turnaround times for conventional testing and DBS and phlebotomy was a lot longer than it would have been prior to the pilot. So first model is a much more realistic comparison, I think, of the relative impact of point-of-care testing in this prison. So moving on to the cost analysis, you can see on the left-hand side of your screen here the different methods with the 3 columns there for conventional testing in the pre-pilot phase, and then gene expert testing during the pilot, and conventional during the pilot too. And the bottom line here with the red arrows, you can see in comparisons across the columns there that there was no favorable cost analysis taking into account all the testing on treatment costs relative to cure for the point of care test methods. This included when you discounted your medication rates. However, if you did sort of vary your assumptions a little and assume, like I said earlier, there was a higher loss to follow-up rate in the point of care group than there was in the conventional tested groups. But if you assumed across all groups that anyone who was lost to follow-up achieved a cure, which is not an unreasonable assumption given the efficacy of DAAs these days, we did observe one favorable cost scenario for the gene expert relative to that pre-pilot phase conventionally tested group. And like I mentioned before, it's probably a much more realistic comparison to make rather than that within pilot comparison, that the pre-pilot and pilot phase conventional testing or point of care testing, there was potentially a favorable cost scenario there. In the qualitative analysis, there's a few different themes. I won't touch on in too much detail here, but it crossed quite a few different areas in terms of planning and professional identity, staff behavior and workflow and so on. I'll refer you to the paper for a bit more detail. But how this played out across the framework that we used, so there's 5 different domains within this framework. You can see on the screen here a little graphic. We did 5 interviews and they covered across nurses, healthcare assistants, biomedical staff and different service leaders. But starting sort of in that grey section on the right-hand side there in the inner setting of the framework, there's mostly barriers, and this related typically to staff turnover and environmental limitations in the prisons, so being able to access different areas and so on with the gene expert and move it around. We kind of had it mobile to move around the health centre on a trolley. There are some challenges there. In terms of characteristic of individuals, it's a pretty even split across self-efficacy and wider knowledge of intervention before we took it on in the prison. Moving into the processes, mostly barriers. So results reporting was a key challenge in this project, as we'll come on to in a minute. And sample acquisition, some staff found that difficult. In terms of the intervention itself, it was an even split. So we are comparing, again, that challenge of sample acquisition, as I mentioned, to really quick turnaround of results, which are really beneficial for some patients. And then the only domain, if you like, that we noted mostly facilitators within was the outer setting, and that was a wider policy context as well as perceived patient preferences for this type of testing. And a few examples, I don't have any quotation here, and I'd refer you to the paper for that, but in terms of the intervention, lab staff and BVV staff found it kind of hard to interpret the way that viral load is reported on the device, which led to a fair bit of confusion when lab staff were trying to upload it into people's digital health records. So it was probably a learning for Cepheid to try to change the way they do that. But it was perceived as a preferable method due to the speed of the results. When you move to the inner setting, the framework, within the prison, we found it difficult to implement due to high staff turnover, as I mentioned, but the core BVV team that were in place there had a really good ethos in terms of innovation and openness to change. So that was really helpful in terms of getting this delivered. In terms of the wider outer setting, the lab staff in hospitals, one example, found it difficult to delegate. They wanted to delegate sort of certain reporting aspects of this sort of workflow to lower banded staff, but were unable to do so due to professional regulations, which caused a bit of tension both within the lab and between the nursing staff and the health centre and the lab as well. But the sort of wider policy context was generally facilitative, and that elimination strategy within Tayside and Scotland. In terms of individual characteristics, some staff within the prison, testing staff, just preferred to take venous samples. That led them to choose it more often, and that's fine. But it obviously led to a reduced uptake in terms of proportionate tests which are performed with point-of-care RNA. But within a lab, for example, one individual appreciated the challenges of prison healthcare and was aware of gene expert prison testing in a project in Wales before, and really helped us to make the case to leaders within the sort of lab setting in the hospital to take this project on and support it. And that was helpful. Finally, looking at the processes, we did have a manual reporting process because we weren't able, due to the various challenges of the prison in question, to get an IT link in place for digital or electronic automated reporting. That was a huge barrier, and it made lab staff and testing staff very anxious. But because it was such a simple process, if you like, the labs were able to really easily amend their IT systems to integrate this as a testing option for us. So just a few discussion points and take-home messages. I think we can say that point-of-care testing with this device did improve time to treatment and increased your likelihood of starting treatment sooner after you had that test. But the improvements that we had were pretty modest compared to some other studies, some of which might be getting presented at this webinar, I think, from Australia and from London as well. Probably because we didn't really make other changes to the pathway to try to sort of accelerate transition through other than testing. The cost implications are pretty uncertain and really dependent on what's the follow-up, and the methods weren't that robust. So I think just for further research and work that could be fruitfully done there in terms of the cost benefit of testing like this in prisons. Just some general learnings I've put on the screen there. So try to get an electronic reporting system in place if you're going to do this. Have regularly interval staff retraining and training to try to increase the success of testing with the assays and reduce the proportion of failed tests. Be aware that professional regulations may impact delivery, and take account of that, and try to work with stakeholders to reduce the likelihood of that happening over time, and try to foster a good team ethos that will take these sort of projects on. I would say as one take-home message that the Gene Expert isn't a silver bullet, and I think you should offer more than one option. So if you wanted to offer, full blood-borne virus screens, Hep B, HIV, and Hep C in a prison, you'd have to have multiple assays, and they're quite expensive with the Gene Expert, and compare that to DBS, which gives you a full screen with minimal additional costs. So, pros and cons. And try to get advocates within the prison who are resident to help get people on board. I'm pulling some of these learnings out of wider work within the project that I haven't sort of presented. So again, refer you to the paper just to sort of get more context on those take-home messages. Finally, just to acknowledge quite a lot of the people who are involved in this project that haven't presented this work, but I didn't do this all on my own, obviously. And just finally say thank you for your time. And if you have any questions, please do reach out on either of these email addresses. I'm very happy to go back and forth on any discussion points that have come up. And I'm sorry that I can't join you for the discussion. Just had a conflicting things that were on that I couldn't join. Thank you very much.
Thanks so much to Chris for sending that in, Chris, wherever you are. And also thank you for answering the questions that I had during your presentation. I was interested in the time to point of care RNA testing, and it's really interesting that Gene Expert testing is not a silver bullet. It needs to be coupled with implementation challenges and changes, which Yumi helped to outline. We can discuss in the chat. We're going to go to Quamrun next. As a reminder, please keep the questions coming, and there's a couple for you. Thanks for answering one of them, I think. And Yumi, there's a question for you in the chat as well, if you can start formulating answers. And we'll pass it over to Quamrun for her recorded presentation. Thanks, Liv.
Good afternoon. I'm Quamrun Masuda. I work for the Virginia Department of Corrections in USA. Together with the team members, we conducted research on hepatitis C treatment and published our findings in the Journal of Correctional Healthcare. On behalf of our team, I present here our research outcomes. I'm glad that I get this opportunity to share our experience with you. Our first objective was to set up a pharmacist-led telemedicine clinic to provide hepatitis C treatment to the incarcerated inmates. The second objective was to define the logistics of the treatment. The third objective was to determine our clinical and economic outcomes. And finally, to present the hepatitis C treatment cascade from referral through completion and document the sustained virological response 12 weeks after completion, that is SVR 12. Hepatitis C in Virginia is a reportable disease. It is a leading cause of liver-related deaths due to cirrhosis and hepatocellular carcinoma since 2011 and accelerating since 2013. Published data shows about 0.5% of the Virginians have this infection. Among the inmates of the Department of Corrections, the prevalence is much higher. It is more than 20%. We developed the hepatitis C treatment management strategies, provided care, and contained cost of direct-acting antiviral regimens. We developed and managed this program with the emphasis on clinical guidance, optimizing operational flow, tracking and fostering the budget, training new pharmacist provider and health service providers, tracking clinical and economic outcomes, and fostering continuous quality improvement. We developed a patient consultation template, a follow-up protocol, and a data management system. Most importantly, we established, strengthened, and fostered strong interprofessional relationships with all Virginia Department of Corrections facilities. This study is a non-randomized, retrospective, and prospective cohort study. We obtained ethical approval of this research from the Virginia Department of Corrections Human Studies Research Review Committee. Informed inmate consent was waived because data were de-identified in group statistics. This study describes 1,040 treatment-naive patients' treatment progression. All participants had a positive hepatitis C antibody test and a quantifiable hepatitis C RNA, that is viral load. With few exceptions, their FibroScan scores were within 2 to 9 kilopascal. A few inmates' FibroScan score were in 9 to 14 kilopascal. Average age of the inmates were 42.7 years. Majority were multiple drug abusers and had tattoos taken in the DOC facilities. Hepatitis C medications Epclusa or Mavorate were administered in directly observed therapy format. The regimen were either Epclusa, 1 tablet once a day for 84 days, or Mavorate, 3 tablets once a day for 56 days. Epclusa was our preferred direct-acting antiviral regimen unless patient had chronic kidney disease or less than 6 months incarceration time left. Clinical notes were prepared in subjective, objective, assessment, and plan format, with emphasis on concurrently administered medication management. Patient-centered health education was provided in teach-back format. More than 80% of these inmates were on 1 or more medications for mental health management. Majority were for managing depressive or anxiety symptoms. Treatment progress was monitored at 4 weeks, end of the treatment, that is 8 weeks with Mavorate and 12 weeks with Epclusa, and finally at 12 weeks post-treatment, that is at SVR 12. All participants were entered in master calendar for tracking follow-up. Quantitative determination of hepatitis C RNA, that is the viral load, was done at all follow-up periods. In complicated cases, like patients with F3 stage of fibroscan or platelet counts less than 150 or high liver enzymes, patients were assessed for FIB4, MELD score, and APRE score. Irrespective of initial viral load, with a few exceptions, inmates were clear of hepatitis C RNA at 4 weeks and were cured of hepatitis C infection at 12 weeks post-treatment, that is SBR12. Clinical outcomes, SBR12 of this treatment was 97%. A few of the inmates were released before achieving SBR12. We were not allowed to contact them once they were released. Economic outcome. Our average cost to cure ratio was only $23,223 per inmate, as opposed to the range of $74,380 to $189,900 per patient, reported in the literature. I believe our DOT administration of the hepatitis C medication and the master calendar tracking for treatment follow-up were the main contributing factors for this significant difference. Our hepatitis C treatment cascade is very impressive. During our study period, a total of 1,040 inmates were classified as hepatitis C antibody positive at intake testing. They all have quantifiable viral load. 3 of them exercised their right to refuse for treatment. 4 of them were released even before starting the treatment, and 12 of them started but were released before completing the regimen. 22 inmates completed the regimen but were released before reaching to SBR12. All these transitions left us with 1,006 inmates, and they all are cured at SBR12. Thank you for the opportunity to present our findings. If you have any question, please feel free to reach out to me.
Thanks so much to Quamrun for sending that in. Really, really impressive care cascade in the Virginia DOC. We'll hand it over to Behzad for the last talk, and we're a little over time, so we'll have a bit of a shortened Q&A, but there will be some time to get your questions in, so please keep them coming.
Thank you, Matt. I'm just trying to share my screen. Okay. Can you see the slides?
Yeah, you're great.
Okay, thank you. Thank you very much for the invitation. And yeah, I'm trying to make the presentation shorter than we have probably longer time for the Q&A. On behalf of my co-authors, I'm presenting a kind of sub-analysis of the STOP-C study looking at the incidence of hepatitis C in the prison. The full text has been published in the journal Viral Hepatitis in case anyone is interested. STOP-C project was a partnership project which was funded by the Australian National Health and Medical Research Council and also Gilead Science, but with involvement of several partners that you can see on the slide. I have no disclosure. Probably the background has been covered by a previous presentation. maybe the main justification for doing this study is the limited data of the HCV incidence, mainly because of the challenges for setting up and conducting a kind of cohort study with the longitudinal follow-up in the prison setting. The STOP-C study, the original study, was designed to evaluate the feasibility and effectiveness of the hepatitis C treatment as prevention in the prison. But in this analysis, we are evaluating the overall HCV incidence and also factors, particularly injected drug use factors associated with the risk of HCV infection. The study was conducted in 4 prisons in New South Wales, Australia, 2 maximum security prisons, both of them, they were men prison, and 2 medium security prison. One of them was men and the other one was women prison. All of the prison inmates over the age of 18, they were eligible for inclusion, irrespective of the HCV status or risk behaviors or any other characteristics. All the participants, they were tested for HCV at enrollment, based on which we had 3 groups of the patients. The people with HCV infection, the red box, they were referred for treatment, and 2 other groups of the people, they were at risk of HCV, either as a kind of at risk of primary infection or reinfection. And these people, they were tested every 3 to 6 months to evaluate the incident HCV cases. In overall, we enrolled 3,691 participants, out of which about 3,300, they were at risk of HCV. And these people included people who had HCV antibody negative at enrollment, at the screening, people who were antibody positive, but they had HCV RNA negative, again, at the screening of enrollment. And the last group, they are the people who were HCV RNA positive, but they were cleared during the follow-up, either through spontaneous clearance or through treatment. Then addition of these 3 groups gave us about 3,300 people who were at risk of HCV, and that was the incidence evaluation population for us. And among these people, among about half of them, they were actually, they were not included in this analysis because we didn't have any follow-up of them. The majority of them, as you can see in the slides, that was due to release or transferring to another prison. Then we have about 1,600 people with the follow-up, which, considering the time follow-up, gave us about 1,800 years of follow-up. Among these people, 106, they had incident HCV. 5 participants, they had actually 2 incident episodes. They had incident HCV first, then they cleared the virus, and then another incident cases. Then in total, we had 111 events of HCV incidents in our study. Looking at the basic characteristics of the participants, as expected, a large majority, they were men, 33 years median age. About half of the population, they had a history of injecting drug use, and 20%, they were actually recent, they had recent injecting. They injected in the past month in the prison. And in this population, over 80% of them, they shared injecting equipment. Then we have a kind of very high-risk subpopulation in the prison who recently injected and also shared injecting behaviors. We also, about 400 people they had a history of injecting drug use in the current imprisonments. In this population, the OAT status, the opioid agonist therapy, about 25% of them, they were receiving OAT, 7% they were receiving low dose, and 18% they were receiving high dose OAT. Okay, going to the HCV incidence data, the overall incidence was about 6 per 100,000 years. The primary infection incidence was 4.6, and the reinfection incidence was a little bit higher, 9.3 per 100,000 years. Looking at the different subgroups of the population based on the injecting drug use status, you can see that we had a substantially higher incidence among the people who injected drugs in the quarantine prison. About 15 per 100,000 years, coming down to just over 1% per year among the people who reported never injecting. Then it is important to consider that overall incidence should be interpreted based on the risk behaviors, because we have a very, very wide variation in the risk and the incidence across the different subgroups. Another important subgroup or interesting for us in this study was the people who stayed in the prison for the entire follow-up period versus the people who released and reincarcerated during the follow-up. And the incidence in the people who released and reincarcerated was higher than the second group. Looking at the factors associated with the HCV risk in all participants, older age was associated with actually lower risk. As I mentioned in the previous slide, people who released and reincarcerated, they had higher risk. And obviously the people who inject drugs, particularly the people who injected in the past month, they had substantially higher risk of infection compared to people who never injected. However, looking at the subpopulation who reported injecting in the past month in prison, in these population, we just looked at a kind of more detailed injecting behavior, and age still was significant. Among the people who received OAT, they actually had lower risk. However, only those people who received high dose OAT, that difference was significant. Then about 75% lower risk in the people who had high dose OAT compared to people who did not receive OAT. And in terms of the sharing of needle and syringes, people who shared needle and syringe, they had higher risk, but particularly significant higher risk was among the people who shared, but they did not use disinfectant. And I have to quickly explain about that. In New South Wales prisons, there were a kind of bleach-like substance for the people in prison to kind of clean or disinfect the needle and syringe after use, because there is no needle and syringe program in the prison. There are some challenges about how the prisoners are using this facility, or if they use properly or not. But and there are different data about that. This analysis shows that it looks like that the cleaning the needle and syringes is important, or at least somehow effective in terms of the decreasing the risk. But there are other data which is actually a little bit different from this. Okay, in conclusion, our study shows a very high HCV transmission and high incidence, particularly in terms of in the group of people who had ongoing injecting drug use. Also, another group at risk, they were the people who released and reincarcerated. They had higher risk of HCV and also high dosage OAT. Probably that's the main factor as a kind of protective factor to decrease the risk. And in general, we need high-level HCV screening and treatment in prison, and also we need a kind of enhancement in the HCV prevention strategies and harm reduction services in the prison to be able to control the HCV transmission. I have to also acknowledge the whole broad people who helped us in this project in different capacity. Thank you very much.
Thanks so much, Behzad. Amazing work. The whole STOP-C study was so incredible, and this was such an amazing extension on it. We're going to go into the Q&A. We only have about 15 minutes, unfortunately, but maybe I want to make sure we get one substantial question in for all of the presenters who are live. So that will be for Anne, Yumi, and Behzad. If you have any questions that you want to ask live, please feel free to raise your hand. There was one question, Anne, that you answered in the chat. Andrew, I don't know if you're able to unmute and ask your question about grading of evidence. I think that will provoke some really interesting discussion.
Yeah. So, Anne, thanks so much. I totally recognize the major challenge to unlock the key and gather information from the correctional system. So you've done a great job. But you can tell that there may well be vagaries about the quality of the data that you've been given from different states. And so I wondered if you could do some kind of a grading or evaluation of the quality of the data to help interpret the variation.
Yeah, thank you for that question about trying to figure out the quality. Some of the data we may have been given only antibody, may have only been given viremia data, and we'd have to either multiply the antibody by 0.75 if we think that they're not treating, or do a back calculation and get antibody from a viremia data if we have an idea of how aggressively they're treating. But beyond that, some of the indications that we don't think the data are very reliable, maybe the year that they lasted a survey. So one system seems to have done one study like 10 years ago, and they still think that is current. Others, I am just very impressed by the California Department of Corrections, which has a very robust electronic health record, and can give you cross-sectional prevalence data, and just up to the minute data on how many people are getting treated. And I feel like that is kind of at one end of the spectrum. And then there are systems that are not even testing. One of the state systems does not have a medical director, and it's all over the place.
Thanks, and
So,
Michael Levy has a comment in the chat about grading evidence where informed consent hasn't been obtained, the level of evidence equals 0, which I think is not, it's an interesting point.
I'm not sure what that means.
Michael, I don't know if you're able to potentially unmute to raise that question or raise that comment. But I know that this study, being part of that team that conducted this study, the challenge in the US is it's just so heterogeneous in terms of what's available. So we were trying to pull data from many different sources and doing the best we could with that.
Yeah, but some of the data are just administrative records. So it's not that we are trying to coerce data out of persons who don't want to disclose anything. We're basically looking at, some of this is just like quality assurance data. Do you know how many people in your system still have infection? And I think if people are just giving data by looking at their medical records of like how many people tested positive, gave consent for care, and they're just trying to figure out plan forward how many people have infection, I don't think that that data, it does not correspond to whatever the truth is. It is X number of people are people who need to get the healthcare system to buy treatment for. And there's almost, I feel like I've been confronted by a lot of people that say that if we don't have this done in a separate study apart from the healthcare system and have people volunteer to get tested, and then we'll be able to extrapolate. I'm not sure that the data from a formal individual testing outside of the medical system is superior to just the healthcare system saying X number of people are in our prison. We've tested, we've had everybody either sign a consent to be tested or signed a refusal to be tested. X% are consenting to be tested. And this is what the lab data data show. This is basically health systems data.
Yeah, no, thanks, Anne. Just in the interest of time, I'm going to pass it over to co-moderator Nanzo. Nanzo, are you able to unmute to ask your question?
Yeah, thanks. Thanks for doing our job effectively. Thank you so much. My internet has been unstable, but for the questions, my questions go straight to Yumi. Normally, interprofessional relationship within the prison among the health workers, the prison staff is always a problem in carrying out health intervention in prison. So I noticed you said you had a dedicated nurse and a dedicated prison staff. Were just the two of them, was that just enough to make your research effective, or were there other hindrances that were relationship based while we are carrying out the research? Then secondly, the costs. From the pharmacist presentation, they had a massive drop from about $75,000 to $23,000, which is a massive drop, but are still quite expensive per cure. I know you also use DAAs. I wanted to know, how did you also go about your the price of your medication?
Thanks, Nanso, for those questions. So I'll answer the first one, which was about relationships, but real relationship building between correctional officers and the healthcare work, or the health sector. So yes, we did have a dedicated correctional officer and a dedicated nurse, which was a huge facilitator. But we also had spent a lot of time negotiating with the local site, so the one prison that we were working at, to make sure that we had the all of the correctional staff on board, and in particular the governor, so the boss of the prison. He was a very supportive, very supportive of research, which helped with a lot of, I guess, the negotiations that trickled down through the rest of the correctional sector at the prison. And we also had a really supportive health team at the prison, but it was really, I guess, came down to having that dedicated officer who could bring people to and from the cells and from the blocks up to the clinic, and having our full-time research nurse. But we do know that it's important to have those relationships built in advance with all of the stakeholders in a center or in a sector. And then the second question was around DAAs and the pricing of DAAs. So in Australia, we're fortunate that the drugs are actually covered through our national pharmaceuticals benefit scheme. And so cost was not a huge issue for our study or for the individuals, or kind of out of our budgets. And so it's tricky for me to comment on that any further.
Thanks so much, you. And thanks for the question, Nanzo. Are there any other questions from the audience if you want to raise your hands? If not, I had a question for Behzad. I want to make sure we get a question in for Behzad. There was a pretty substantial loss to follow-up. About 1,600 people were not included in the incidence analysis. Do you think that had those people been included, that the incidence would actually be higher? Like, are those people who were lost to follow-up because they were released from prison because they were on lower level charges like drug-related charges, and therefore could have inflated the incidence even higher than what was observed.
Yeah, thank you, Matt. That's a very important question. Yeah, we were actually a little bit concerned about the selection bias because of that 50% loss to follow-up. The only evaluation that we could do to at least measure if or the magnitude of the selection bias was to compare the basic characteristics between these population, people who had follow-up and people who didn't, in terms of the injecting drug use behavior, etc. And it shows that they were very comparable. And for example, 20% recent injecting versus 18% in other group. The people who left prison, a little bit lower proportion of them, they were on OAT, probably because of the waiting list in the prison for the OAT, and they were just released before started that. Then it might be the risk in the people who left the prison a little bit lower, a little bit higher because of the OAT, but I don't think that hugely impacts the results. That might, based on the data that we have.
Thanks, Behzad. I was blown away by how much injection was actually going on in prison in Australia, and just really, you know, a severe need for prison NSPs and increased harm reduction in prisons. I think, unfortunately, we have to leave it there. We only have 3 minutes. I want to make sure that we're able to close on time. So thank you so much to our amazing presenters with these incredible papers. Just some words of closing. I think, you know, in summary, surveillance, we saw from Anne's paper, is really challenging, especially in a heterogeneous country like the US, but it's really key to inform elimination efforts. Time to diagnosis really matters. We saw that from Yumi and Chris's study, and that the gene expert point of care RNA testing may not be a one size fits all. It's a great innovation, but not necessarily a silver bullet. We saw from Quamrun's presentation that task shifting is really important, and involvement of other providers like pharmacists, NPs, PAs is really going to be important for advancing elimination efforts. And then just the high risk transmission and high incidence, especially within prison, among people who are actively injecting, but also upon return to the community, from Behzad's amazing talk. If you have any other questions for the presenters, please feel free to email us or put them in the chat now, and we'll try and collate them. Thank you again to our presenters. I just want to highlight INSU Prison's activities. So we had an inaugural annual workshop in Montreal in 2019. This was really the kickoff of INSU Prisons. We've also participated in the INSU Africa conference in 2020 in Cape Town. We've had some successful pre-conference workshops in Glasgow, adjacent to INSU 2022. That was in partnership with the Coalition for Global Hepatitis Elimination, and then another pre-conference workshop in Geneva just last year. We have another annual workshop coming up for INSU Athens in October, so we really want to invite you to attend that, especially people who are interested in the prison sector. We welcome you to reach out to us about that and to attend INSU, but also the INSU Prisons pre-conference workshop. We're also working on an advocacy toolkit project, which we're hoping to launch at the Prisons workshop in Athens. It's a toolkit to promote advocacy in prison settings, where there will be tools for multi-sector, high-income, middle-income, and lower middle-income country resources. And lastly, we have an International Journal of Drug Policy special issue coming out, which has not been announced yet, but we wanted to give you a bit of a sneak peek to that. It's going to be on elimination of hepatitis C and other infectious diseases in prisons and jails and other carceral settings, ensuring access to equitable prevention, treatment, and care. So that'll be open soon, and we're welcoming submissions to that. With that, to close us on time, if there are no other questions or comments, please feel free to reach out to us to join our mailing list, to become a member. To do that, you can email us at info@insu.org. And for more information about the network and upcoming events, you can always visit our website.